all of you to our 7th Dementia-Friendly Tempe Summit event. So thank you. This is our 7th year, and this has been really the largest one we had. So thank you. Thank you for coming. I hope that you enjoyed our wonderful breakfast that we catered for you. Thank you. And our breakfast was paid by AARP. I want to recognize them, so thank you. We also had our art gallery. If you notice in the back, the artwork came from our memory cafe by our loved ones. And so we had one session and they did a fabulous job. So please take time, at the end and look at those, fine work that they have done. And also the resource fair that we put together for you. I hope you were able to go around and really talk to every one of them and enjoy, and grab as much as resource as you can. And if there are other questions that you need, you're welcome to email us. Our business card is at the front. My name is Seema Garagozli, and I am the senior coordinator for the Dementia Friendly Tempe programs and the Age Friendly Tempe initiative. So thank you, of course. Our first speakers are going to be Mrs. Marie Raymond. And Marie is a manager in the City of Tempe Office of Education, Career, and Family Services. She administers mayoral and council initiatives such as Read on Tempe, College Connect, and Age Friendly Tempe, which is our program, and Tempe Pre and Workforce Development. So she has a lot of responsibilities, and she is my supervisor, and she's wonderful. So please welcome Marie Raymond.
Thank you, Seema. Thank you for the introduction, and thank you for coordinating this amazing event. The idea for Tempe becoming part of a national network seeking to ensure communities across the U.S. are equipped to support people living with dementia and their caregivers began when Mark Mitchell, former mayor of Tempe, became caregiver to his mother, Mary Ann, who was diagnosed with Alzheimer's disease. He learned about Dementia Friendly America and became an advocate for the concept, resulting in Tempe leading Arizona and becoming the state's first designated community and 5th in the nation. In March of 2016, with our partner Banner Alzheimer's Institute, we hosted our first summit. Today, we welcome you to our 7th annual Dementia Friendly Tempe Summit, focusing on revolutionizing Alzheimer's disease. Tempe has served as a model for the state of Arizona, where we now have 10 dementia-friendly communities, including all of Pima County. Our Memory Cafe has also been a model and inspiration not only for many cities, but private organizations are also hosting these gatherings that welcome people living with dementia and their care partners. We are proud of the Tempe leadership who are making it possible for people with dementia to live well in their communities while also better supporting their family caregivers. If you're not familiar with Dementia Friendly Tempe, it's an initiative with programs and resources for families of people living with memory loss. We have Memory Cafe, which meets 4 times a month right here at Pyle Adult Recreation Center for both caregivers and their family members. For the loved ones, they meet with a paid facilitator for activities to stimulate their brain and memories. And for caregivers, we have our support group led by an experienced volunteer facilitator who has been a family caregiver. We also have new bilingual English-Spanish monthly memory cafes at the Escalante Community Center. And you can get more information by visiting our dementia-friendly Tempe table in the lobby. We're also looking for volunteers who are Tempe residents and who would like to join our bi-monthly dementia-friendly Tempe action team. This committee is essential in helping to evaluate and plan for dementia-related programming in Tempe, like the summit. If you're interested, Please let us know by visiting our dementia-friendly Tempe table in the lobby or by indicating your interest on the evaluation form in your packet. So we know from various surveys and research in our community that people want Tempe to be a place that is livable and welcoming for all ages and life situations. And as such, we are looking into identifying areas that may benefit from additional supports or new programs and services. Education is a cornerstone of Dementia-Friendly Tempe, and I am so excited for this year's summit topic. What if Alzheimer's could be predicted and prevented before it was too late? Today, we will learn how blood tests and genetic testing could transform the disease's diagnosis and treatment. So our panel will discuss and take questions on topics that include the emerging role of Alzheimer's blood tests in diagnosis and treatment, the future of Alzheimer's disease genetic testing and counseling, and the ethics of knowing your status from Alzheimer's biomarker blood tests. If you look at the printed program for today's summit, you will see the lineup of speakers. On the back of the program is a list of website and contact information. So now let me introduce to you the wonderful people who are with us today. So our experts are Dr. Danny Cabral, dual board-certified neurologist and psychiatrist specializing in Alzheimer's and related dementia, and an assistant professor at the University of Arizona College of Medicine, Departments of Neurology and Psychiatry. Catherine Hunt Brendish, director of the Genetic Counseling Program and clinical professor, and Jason Robert, philosopher and ethicist in the School of Life Sciences at Arizona State University. And we are also grateful to have Shelley with us today to share her perspectives as an Alzheimer's prevention clinical trial participant. Thank you to our speakers and to you all for attending. Now I'm going to turn it over to Jan Doherty, who will give you more information specific to today's program. Jan is an important reason that we have Dementia-Friendly Tempe in this annual summit. She is formerly with the Banner Alzheimer's Institute and is now president of Travals, which helps families with a loved one with memory loss plan and execute successful travel. And so I present Jan.
That's fine. Let me just turn it off. Do you want to hold it? Do you want to hold the mic? All right. Okay, well, thank you for being here. I am really excited. So I had the pleasure of working with then Mayor Mitchell and forming a wonderful action team and working with a very responsive city. So I'm a Tempe resident, and I am a nurse who has spent her whole career pretty much in this field. So it's something I cared very much about, was how is it that we welcome and support people living with dementia and their families in our own community. And I can't say enough for a city who puts their money where their mouth is. So this started with a grant from the Virginia Piper Foundation through Banner Alzheimer's Institute. But very early on, the city understood that this was dementia-friendly Tempe, not dementia-friendly Banner, and that they were going to have to commit to this, and they have in a very big way. So I want to recognize Seema and Linnea in particular for their commitment in carrying on this amazing work. And really, Tempe has become the model for how other communities are rolling out their dementia-friendly efforts. So this is just remarkable. And you know, when we met in 2016, it was March of 2016, we're at the Tempe Center for the Arts, and we were lucky to get the room because remember the bladder broke on the lake, so we got the room for free, and we had a wonderful summit hearing from our families and people living with dementia and community partners about what they needed. And I have to say that I think our city has done just an amazing job really stepping up, trying to raise awareness, trying to create safe places and programs for people who live with Alzheimer's disease or related conditions to be able to come. I also want to recognize today, Tempe Adult Day Healthcare is providing respite care. Again, that has made us very unique and set a standard that we believe that people with dementia should not be left at home,
that we need to support them and provide programming that works. So I am incredibly grateful for Tempe Adult Day Health always stepping up, and our partners Oakwood Creative Care have done so in the past as well. So we are a very blessed community. I'm also reminded, having been a nurse in this field forever and getting closer to age-related, right, changes in memory and thinking. I mean, it happens. Things change. We never think we're going to get old, and then we wake up and see a picture of ourselves and go, oh my, I guess I am. I am so delighted that we have got such an outstanding panel. I mean, most of you would have to go to a national meeting to hear people like this, but we have them here. And I have the distinct pleasure of introducing my friend and colleague, Dr. Danny Cabral. And I will tell you, we go back to about 2005 when Danny moved to Arizona to study for her MCATs. So she decided she was going to go to medical school. Shabby resume, by the way. She graduated from Vassar, and so she came to work with me as an administrative assistant. I was then the director of Hospice of the Valley Dementia Program. And she studied for MCATs. She got into the University of Arizona. She was the graduate of the first medical school program here in Phoenix, and then went on to Brown University, not only to do a neurology residency, but a psychiatry residency. So this is a woman who is steeped in kind of whole mind, body, spirit, gets the connection. And then if that weren't enough, she went on to do a fellowship in neurodegenerative research. So she is truly an expert and has also seen the transformation of a field that once felt pretty hopeless to where now we are encouraged by the progress. We're not there yet, and maybe in my lifetime, if I live long enough, we will. But that's good news, right, for our children and our grandchildren. So with that, thank you, Danny, for being here, for being now a new leader, right? We need younger people to follow us in the field to carry on this important work. So she's going to lead just a really dynamic discussion.
All right, you guys know how to go with the flow in the world that you're living in, I'm sure. So I'm gonna use this abbreviation, sometimes AD, for Alzheimer's disease. So to really, again, ground this into this is a quote from a caregiver that, speaking of occupational therapy, which is going to play an important role in this experience of. So this is a caregiver saying this, and I wasn't aware that you were going to have the sound, but that's exciting. So I'm going to say it for you, and this is from an occupational therapy showcase that just happened with occupational therapists working with caregivers. All right. So a diagnosis of some form of dementia is given, rather matter-of-factly. We hear it, but don't really comprehend it. We go home with slick, colorful brochures with sunny pictures of the medical facility, complete with smiling patients and caring doctors, all robust and healthy. Inside, more colorful pages, lists of service providers with sophisticated is there a ghost? Yet generic names like Senior Care Consortium, as if we understood what it all means. We try to place the seriousness of this disease somewhere between melanoma and a recoverable stroke. We read the material, searching the contradicting mysteries of internet, and develop a routine. We are grossly unprepared for the loss of ourselves and genuinely surprised when we realize it. All right. Yeah, why don't you want to advance it, and I can. I was trying to remove my fingerprints the other day. Yeah. Do you want to just? I'll just say advance it. All right. So until recently, we would diagnose as a clinician. We would diagnose Alzheimer's disease by clinical symptoms. So someone. And this still happens mostly, actually. So you'd go, this is 1984, the diagnostic criteria for Alzheimer's disease. This is probably what your doctor looked like in 1984. The reason that everyone thinks, or did think until recently, that the only way to truly diagnose Alzheimer's disease was with a brain autopsy is because that was the criteria from 1984 until it was revised 27 years later. Did I do the math right? So, but the truth is that's changed, and that's what we're going to talk about today, that we can diagnose this during life accurately. And so, your doctor would just look at you and say, yep, you have Alzheimer's disease, you have memory loss, it's been progressive. Now you can see the downside to that in terms of appropriate treatment and counseling. Then we have 2011. We've had a series of advances in our understanding of the disease, what's actually happening in the brain of someone with Alzheimer's disease, instead of just assuming everyone who has memory loss has Alzheimer's disease who's, over a certain age. And so then we have these categories that develop called, I'm sure you've heard of mild cognitive impairment and dementia, mild, moderate, or severe. And so mild cognitive impairment being that initial stage where there's more trouble than we expect with the thinking, but still functioning independently. Preclinical Alzheimer's disease. Has anyone heard that term before? Raise your hand. I'm not going to call on you. Okay, so not too many. And so that's been what? 12 years now that's been around, and so I'm going to talk more about what that means. And so that's the silent period of no symptoms, but the Alzheimer's changes are building up in the brain. Okay, next slide, please. Oh, sorry, can you go back? So the reason so that's your doctor in 2011, plus minus. So these criteria said we have some we have this ability now to detect some of these changes in the brain during life, but they're not essential to diagnosis. So you can imagine we then are still having imprecise diagnoses of if someone actually has Alzheimer's disease or something else. Next slide. So why is it difficult to diagnose Alzheimer's disease? Well, many, many reasons, as you know, right? The system doesn't support what is truly needed. And I think primary care doctors really know that, and that's my impression of why it's not diagnosed sooner, is because they know once it's diagnosed, these people need help and they know it, and they need lots of support and services that aren't reimbursed, which is really frustrating. As well, the presentations, the person's symptoms, everyone's unique, everyone's different. There's usually multiple things going on. That's why I like working with older adults, because I think people get more and more interesting and unique, and it's often multifactorial. And so when someone would come to the clinic to see me, I'd say, you're going to get a tune-up, I'm going to ask you questions for 90 minutes, and I end up giving a whole bunch of recommendations. And the end might be, no, you don't have Alzheimer's disease, but you do have probably undiagnosed sleep apnea, poor sleep hygiene, maybe you shouldn't drink that, 2 glasses of wine right before bed, you're stressed out, blah, blah, blah. So a lot of recommendations. It's difficult to screen people in terms of, it's not easy. I can't just say, draw a clock. Now I know what's going on with you. And that's unfortunately, with the time that we have in the clinic, oftentimes, in primary care especially, that's what they have to rely on. So I'm not going to go through all this, but this is everything that's happened in the field of Alzheimer's disease in 125 years. So starting with our first patient described by Dr. Alzheimer, and I'll talk a little bit more about that. But what I wanted to highlight was the red arrows here point to when the biologic changes, the ability for us to test for these things were discovered. So first in the mid-90s, the cerebrospinal fluid, we learned how to detect the amyloid and the tau, the 2 hallmarks of Alzheimer's disease in there. And that's through a lumbar puncture, which maybe some of you are familiar with. This fluid is so valuable, and it's really not that hard to get. It's really not that invasive a procedure, and I would do this all the time with patients and research participants. And to me, it's the only thing we have that's reflecting really what's going on in the brain and spinal cord, and it's in this enclosed special space. So it's still, will continue to be crucial as we learn about other neurodegenerative diseases like Lewy body disease. And then fast forward 10 years, amyloid PET scan, amyloid imaging was developed so we can scan the brain and detect the amyloid plaques. And then tau imaging 10 years later. And then we have the blood tests up here. So these were approved via the FDA as breakthrough designation, specifically for people who are mildly symptomatic. So these aren't yet covered by insurance, and I'll talk more about that. And then you see, so you're seeing also on the top of above the arrow treatments. We've had 300 plus negative trials until recently. We've had some positive trials, and I'm sure you've heard about these in the news. A lot of questions about those, about how we're going to actually do this well in the real world. And then the bottom is all the diagnostic criteria that have evolved. But we're still in the 2011 criteria, and a lot of these are research criteria. So a lot of work to do. So this is our first patient, that Dr. Alzheimer. He was a psychiatrist and a pathologist in Germany, and this woman, you can see she's very young when she died. She was 56. So she was an early onset patient who actually had psychiatric symptoms. So an atypical presentation. And he had seen some people like this come through, but he realized something's different about this person. And so, reportedly she would repeat this phrase, Ich habe mich verloren. Thank you, Herr Schneider, in my German college class. I've lost myself, which is very chilling, but also I bet everyone, also caregivers in here, are saying this to themselves frequently. So if we go to the next slide. So she was the first patient that we discovered that we had the biomarkers for, because what he did is, even though he left that facility, he would check on her, and when she died, he got permission from her husband to look at her brain. He saw these, got her brain autopsied, looked at the microscope, saw the amyloid plaques and the tau tangles, and those are different than the normal brain. And then this progressive memory disease was called Alzheimer's disease. I want to just highlight that I'm all about, because of Jan and end-of-life dementia care, thinking about, well, who is this person? So there's no pictures of Auguste Dieter besides this one. And as a woman, her picture that exists in the world forever, and she's dehumanized here. She's just a disease. Dr. Alzheimer looks like a stud, right? And so she apparently grew up in a working class family and somehow got very well educated, raised a family. And so this is really at the heart of what needs to change. And so when you have the amyloid and the tau and many other things going on, some of which we know, some of which we don't understand still, the brain starts to atrophy or degenerate or shrink. And this is, of course, an actual brain, normal brain versus Alzheimer's brain, so you can see how much thinner it is, and of course that's going to affect one's thinking and function. So this, for a long time, for decades, was the only way we were really able to diagnose Alzheimer's disease, like I said. And so I like to make comparisons between the whole field of cancer and advances in cancer with where we're at with Alzheimer's. It's very challenging in Alzheimer's because it moves so slowly that we need to follow someone in observational research study over many years to try to detect any changes clinically, and then we look at their brain at autopsy and we can see what kinds of things are happening there. So until the last really 15 years, that's been how we learned about Alzheimer's, so it makes sense that the diagnosis has been difficult to be precise. Next slide, please. Now, biomarkers is a term that is being thrown around or used frequently now, and so I think it's important that we're all on the same page with what that means. So biomarkers are used in all kinds of disease processes, and it's something we can measure objectively and quantify that's an indicator of health or disease. And here are some examples. It's basically using our most up-to-date modern technology. And so we get our hemoglobin A1C, fasting blood glucose, to look for diabetes, LDL, HDL, for cholesterol, and then another example is ovarian cancer. This is a blood test that can be done, and then ultrasound to look for that. Also, a biopsy could be done if a tumor is present. So all of these things we call biomarkers. Now, scientists love talking about biomarkers, but sometimes what's lost is, well, how does having elevated hemoglobin A1C actually affect one's life? How does it feel? What are their symptoms? And so it's really, and that's really what matters, and that's what should drive how what we reimburse for in healthcare, right? And that's not really always put forward, but with recent approvals of these, really, I'd say game changer Alzheimer's treatments that are disease-modifying treatments, the rub is great. Your amyloid plaques are going down in the brain, but is it really like helping you in your life? Is it really slowing down the disease in a meaningful way? And it turns out these new treatments do appear to be doing that. Not a cure, but that there's big conversations about that. And so we do all these rating scales for these research studies, and we're like, okay, can you, memory tests and things, but it's like, what's really important to people, right? And so luckily, these conversations are happening now, and including caregivers and people who are actually having the experience. And then we shouldn't just assume that a biomarker is valid if something's a biomarker. We gotta keep studying it, and a lot of our research studies, as you know, are completely lack diversity. And Alzheimer's, unfortunately, is one of the worst with, I think just until recently, like less than 5% of people in Alzheimer's trials, treatment trials, were non-Caucasian. So that needs to change. Luckily, people are talking about that too. Next slide. So I mentioned CS cerebrospinal fluid already, but I'm sure everyone in here is totally comfortable and excited to get a lumbar puncture, right? But not everyone in the world is, and so even though this existed for decades now, it's really not accessible except for in specialty centers and big cities. And you get fluid, and you can test for a lot of things, but it doesn't. There's a lot it doesn't tell you to. So now we do use this in the clinic in specialty centers to diagnose Alzheimer's disease, and I'll talk more about that in a second. Next slide. So then we have our really what changed the game in the field of Alzheimer's research were the biomarkers of the PET scans. So you can do the next slide. Namely the amyloid PET scan. And so this really was integrated into the research studies in the early 2010s, and we learned a tremendous amount. So this is a brain scan. It's a kind of CAT scan where a tracer is injected, and this one identifies amyloid in the brain. So we were able to see, in the brain specifically, what regions is the amyloid building up in, at what progression, where does it start, where does it evolve. So we started to see typical patterns in Alzheimer's disease, where it starts in the medial temporal lobes, which is where your hippocampus is, that short-term memory center, if you remember from your biology class, or your neuroanatomy class. And then we also learned that, and again, this is using PET scans in addition to these observational studies that go on for decades, where they're testing people, they're testing their memory, their mood, then they're doing the brain scans, and they're noticing there's actually other brain pathologies happen commonly with Alzheimer's disease. So this kind of breaks my brain when I think about it. So it looks like 40% of people who have Alzheimer's disease in their brain at death have Lewy body disease changes also. I bet you guys know about Lewy body disease more than most. And then probably 2/3 to 3/4 of people with Lewy body disease changes in the brain. So the Lewy bodies that have the alpha-synuclein in them so most of them have Alzheimer's changes also. And there's other neurodegenerative diseases we've discovered as well, including mimics of Alzheimer's that look just like Alzheimer's. So you have an 85-year-old, 90-year-old person just repeating the same question. Where are we going? Where are we? It's like, but otherwise they're doing pretty well. But it's the memory loss is enough, the short-term memory, that they're not safe to live alone. But otherwise they're doing fine. So it turns out there are these mimics. One of the proteins that is building up is called TDP43 proteinopathy. So this is all still in research, but this is where I think we call these like the pleasantly demented, and they just kind of they don't progress too much. They drop down and they kind of stay. And if you know what a mini mental state exam score, they're like at a 22 out of 30 for like the rest of their lives. So it turns out some of those people do not have Alzheimer's disease. And how meaningful is it to get an amyloid PET scan, and grandma finds out she doesn't have Alzheimer's disease, she has something else, and it's probably this thing that we're still learning about in research, and we will eventually have treatments for. So we learned that there's some people, their symptom isn't memory loss, it's mood changes, anxiety, depression, agitation, irritability, apathy. So their memory's fine, and they're like 60 years old, and they're like getting really cranky, and there's no reason to. And so could be that's going on. So otherwise, this PET scan, this amyloid PET scan, has helped us refine our clinical trials of Alzheimer's disease. So we were studying these anti-amyloid treatments in the 2010s, and similar to the ones that have been approved in the last year. And once the amyloid PET scan was introduced into the trials, we learned that, oh my goodness, 20% of the people in this trial do not have elevated amyloid in their brain, and we're giving them an anti-amyloid IV infusion treatment. So, our study failed. It was negative, and it's probably in part because you didn't have the people who actually had the changes, right? So that's really important that everyone understands that it's not just like the pharmaceutical industry is just spending tons of money on useless studies. It's that this is what we learn over time, and this is why everyone who's involved in any trial is giving so much and such a contribution to our understanding. The PET scan helped us develop the blood-based biomarkers. So the amyloid PET scan and tau PET scan have really become the gold standard that we, during life, are in terms of the level of accuracy to try to meet or surpass. And that's actually the blood tests do seem to be doing that now. And then these emerging disease-modifying treatments, not just emerging. So aducanumab was approved first, and to great controversy, and then lecanemab or Leqembi was approved, and that's being prescribed now, starting to. So we allowed people into those trials with an amyloid PET scan to confirm that they actually had Alzheimer's disease. Next slide. And so with our massive growth and understanding about following people over time, when does the amyloid start? How does it change? The tau, the brain shrinkage. This cool graph table is what we use all the time, and we can see that. So the y-axis is the biomarker, the magnitude of change, and the x is the clinical status, cognitive status. So first we have cognitively normal, mild cognitive impairment, and then dementia. And so the first line that's going up is amyloid. So we know now that starts building up 20, 25 years before any symptoms. Wow. So like many of us in here have amyloid building up. That's a reality. And we don't know if or when that will turn into symptoms, but that's a fact. And then next we have tau building up, and we can identify that on the tau test much closer to when the symptoms start. And then the MRI is that gray one on the right. When we start seeing shrinkage on the MRI, the disease is already pretty advanced, and so that's not a great way. In the long run, that's going to be later in the disease ultimately. So this is this preclinical Alzheimer's disease diagnosis that I mentioned. So no symptoms or very few symptoms, but you have the amyloid and the tau building up. Okay, and so that's where the field is headed to try to get to the disease earlier. Just like in the cancer field, we have our screening tests, we have our mammograms, our colonoscopies. Things are caught early before there's any symptoms, and you're introduced into treatment. Okay. So then we have the blood tests here. Very recently, these were approved, and again, only for mildly symptomatic patients. And this is really still only used in research, probably because it's not paid for. But also the whole thing is in medicine, in clinical medicine, is what action will I take based on these results? How will this change my management as a physician, as a clinician? And primary care doctors aren't really ready or given the kind of education that's needed. But now, again, with these treatments coming online, 5 minutes, thanks. So with these treatments coming online, sometimes people say I'm negative, but I just think it's real talk to say that advances are driven by making profits, and now that there's treatments coming online, that will start conversations and really, I think, get people more of the help they need. And so it's just everyone in this room needs to educate their doctors about this, frankly. So this is a different world. This dementia, any Alzheimer's and any kind of dementia is not the healthcare system, it's not ready for this. So you play a really important role. Next slide. So I just wanted to show you that. So this is the amyloid test, the blood test. This is looking at all of these longitudinal observational studies where they follow people over time and they've tested their blood for amyloid. And this is sort of big specialty centers. So once they have this valid blood test for amyloid, we got to make sure it's actually reproducible, right? Because if you have to go to, San Francisco to get it, that's not going to work. And so what we see is this, on the right, the yellow, the AUC, that's basically the accuracy of the test. And so looking at the plasma or blood test, it's 83 to 87% accurate in these studies, so pretty similar. And then this is just interesting, if you add the ApoE4, that's the genetic test that you'll hear about from Dr. Hunt Brendish, that increases. And so what this is predicting is this truly consistent with the amyloid PET scan and that the person has Alzheimer's disease. So next slide. And so then we also have, after the amyloid blood tests came through, we have tau, and tau is really the game changer here of the blood test. So, so interestingly, the phosphorylated tau, p-tau, that's a specific protein to Alzheimer's disease. The blood test and the 181 and the 217 have been used now in research studies, tracks with the amyloid buildup. So if you have an abnormal p-tau, that indicates that your amyloid PET scan will also be abnormal. And so now trials mainly require this blood test to enter into the study in order to ensure that you actually have Alzheimer's disease in the brain. So this just makes, so it's so much more accessible, less costly, and faster, getting people in. And then there's something, a hot new one called MTBR, microtubule binding region tau 234, which is an indicator of tau and can actually, it's new, so it needs to be validated and reproduced, but really early on, way before symptoms, can show the tau building up. Next slide. So there, this is the evolution of that previous table or graph, and this is incorporating a variety of things. And so I'm not going to go through this entirely, but you can see where the terminology is changing. We're talking about, on the bottom here, primary prevention, secondary prevention, and symptomatic treatment. So secondary prevention is when you have the changes in the brain but no symptoms, and you're trying to prevent symptoms. Primary prevention is now being talked about where you prevent the changes in the brain. And so the way they're studying that is by people who have this autosomal dominant mutation. I'm going to go over my 1 minute. Sorry. So people that have these genetic mutations where if they have it, they know they're going to get it. They're going to get it in their 40s and even younger sometimes. And so studies are being done where they're getting these kinds of disease-modifying treatments for years before before they have any changes. And it seems to be moving thing. It seems to be effective in some ways, but still very early. But exciting things happening. Okay, next slide. So just want to touch on biomarkers versus genetics, because I do hear people changing these words, and so we talked about a biomarker. So genetics in this situation is inherited mutations that increase your risk for a specific disease, something that you're born with. Okay, next slide. So I just want to give an example of ovarian cancer biomarkers versus genetics. I always think it's helpful to analogize to cancer because a lot of us have experience with that. So the diagnostic biomarkers, I mentioned that you can have the blood test, the ultrasound. So that's if it's active in your body. And I'm using this is a personal example. So my mother had ovarian cancer and died at 42. So I've been for decades hearing from my primary care, you should have genetic counseling. And I'm a physician or in medical school and then a physician, and I'm dragging my feet on this. I'm what is this? How's this going to affect my life? Am I just going to become anxious? if I have this BRCA1 or 2 mutation, which increases the risk of ovarian cancer. Yeah, right? So this is so interesting when it happens to yourself. But so just want to mention there's biomarkers for prognosis and treatment of many. And so then like years are going by and I'm like, I'll just keep getting this diagnostic testing, you know? So then next slide. So then I have these 2 spawn here, these little ladies, my kids, and I'm like, oh, now I have to get it because now I have to have the genetic counseling because I need to try to, be here for them. But also, like, they're female, so they should know if they have this as well or be aware of that. So that, each of us has so many factors we're bringing into our decisions to do these things. Next slide. But then if we incorporate these things with Alzheimer's disease, so these are biomarkers. I won't go over all these. Then we have the genetics. The ApoE4 is the big one that Dr. Hunt Brendish will talk more about. Next slide. And so how are we starting to think about integrating all of these for the individual and the family? So there's more attempts to develop dementia risk algorithms. And we have risk algorithms for all sorts of things. Cardiovascular disease, what is your risk of a heart attack based on different things. And so with dementia, these are starting to be developed, and it's complicated. And then we're also incorporating Alzheimer's biomarkers and genetics for these treatments that are coming out. Have you heard about these treatments that have been approved? Yeah, good. She hasn't, but so that would be a great summit next year. But so without trying to say this concisely, so these are treatments that remove the amyloid from the brain, normalize the amyloid. And if you are an ApoE4 carrier, specifically if your 2 copies are a 4, you are at a much higher risk of the serious side effects of these treatments, namely brain microhemorrhages and brain edema. And so it's really if you have 2 copies that becomes much more important. But this is how we're integrating them. And so this is an example of a risk algorithm potentially that we might see in the future, or the primary care providers will see. So this is looking at people in this observational trial study that have either subjective cognitive decline, which I'm sure at least we all would raise our hand on that one, and then mild cognitive impairment. And they're following these people over years and testing these things and looking for, what's the best combination and feasible, easy to get, and that's highly accurate to predict the development of dementia symptoms within 4 years. And so the AUC again over here is the accuracy. So we have 92%, 90%, 89, 81, and then 72, and that's where your doctor's just looking at you and saying, yep, you have Alzheimer's, or you're going to. So we're 72% accurate with that. But just the plasma p-tau, the blood test, with some easy memory and executive function tests, you're at 89% accuracy. In this one study, which is, we have to try to reproduce this in other settings in the real world, because that's an important point. Like, this is an enriched population. These people are going to the specialty center. They have memory concerns, so probably a lot of them more are going to develop symptoms than just the general population that you're screening with these kinds of tests, like your primary care might. So you probably already figured this out, but blood tests, easier to compare to PET scans and lumbar punctures. More accessible, need less infrastructure. You can do this anywhere, all over the world. Increase non-Alzheimer's diagnoses. So you think, you have memory loss, your person has memory loss, your primary care doctor does the blood test. Nope, you don't have Alzheimer's. Great, so let's keep looking. Like, what do you have? And then may reduce unnecessary expensive PETs or lumbar punctures. Next slide. So downsides, and Dr. Hunt Brendish may talk a little bit about this, but getting your blood test and finding this out, stigma, discrimination in a variety of ways. And so you can imagine if you're still working, you're in your 50s, you have your blood test. Like your primary care doctor is not going to order that yet, unless you say, I want to pay $1,200 for this, even though there's nothing technically I can do about it yet, although that there is lifestyle things like aerobic exercise. And also just, the tests, there's doing these tests and research, they're so precise and everything's so monitored and regulated that, whereas in the real world, your blood sample might sit out there the whole day, right? Or like not be put at the appropriate temperature. And so there's so many things to think about. And then I would say the flip side of if you don't have Alzheimer's disease and your provider does this test, they might say, okay, you're good to go. I don't know what's going, you're good, but instead of actually looking for other things. So that could happen, which does happen a lot now. If your MMSE is normal, you're given the stamp of approval of them. Okay, next slide. Next slide. So, yep, not yet reimbursed. Limited clinician experience. I think most will admit they don't know what to say, and we don't know. And yeah, for people who have no symptoms, it's not recommended to do these blood tests at this point. Next slide. Next slide. So just as a shout out to get involved in any way possible, including these longitudinal observational studies where they follow people for years. My former employer, Banner Sun Health Research Institute, has one of the most well-established programs called the Brain and Body Donation Program. It's amazing, and the advances that have happened because of the tissue are profound, and this is all over the world. And so they do, you agree to have your brain autopsied at death, you get a free cremation, or they cover that, which is nice. But and then, so if you're interested, contact Victoria. Next slide. And next slide. So keep in touch. I'm committed to, helping the future of advances in research, but also to helping people now. And so I'm not, I can't share yet what I'm up to, but if you reach out, keep in touch with me. I'm vowing today that in 2024 there'll be something exciting for you. So, thank you. All right, I'm introducing our next speaker. Bio breaks for some. Dr. Catherine Hunt Brendish is the director of the ASU Genetic Counseling Program and a clinical professor at the College of Health Solutions. She has 27 years of 27 years of experience as a genetic counselor, where she worked clinically in the areas of prenatal, pediatric, and adult genetics. Prior to joining ASU, she worked at the Mayo Clinic for 13 years, specializing in cancer, neurology, and cardiology. And at Mayo, she obtained her PhD at ASU in biology and society, and her dissertation and research interests focused on developing strategies to improve the informed consent process for whole genome sequencing. She is currently serving on the board of directors for the Minkoff Center for Jewish Genetics, as well as the program director for the BRCA screening program. Thank you, Dr. Hunt Brendish.
Okay, can you hear me? Okay, thank you. Thank you so much, Danny, and thank you to the organizers of this morning. Thank you, Danny, and thank you to the organizers of this event. It's a great honor to be here. I was telling one of the presenters, Dr. Robert, who's my dissertation advisor, by the way, from ASU. So we also go way, way back. I was telling him this morning when I got here that this is something that I love to do more than anything, is talk with individuals who are interested in learning about their genetic predisposition and helping everyone understand better how genetics plays a role in what matters to you, and then how do you apply that to your life. Because for me, as a genetic counselor, It's so important that people take the information that we give you and take meaning from it, and that we help you incorporate that into your own lives, because we're all different. So that is my goal for today, is to see if we can make that happen. Okay, so what I'd like to do is just start with an overview of what is the genetic contribution to Alzheimer's disease and dementia. There's some overlap with different disorders, but I'm going to take most everything out of the presentation and just really focus on Alzheimer's today. And then I'm going to spend most of the time talking about the complexities that are associated with genetic testing. So you just heard the wonderful presentation about the biomarkers and what's available, not yet available, but may be available. And I'm going to take it from where she left off and talk a little bit about where genetic testing may end up. But before we get there, I'd like to bring up some points about genetic testing that I want all of you to take home with you and think about. And then, of course, I'm a program director for training students to go out in the world and become genetic counselors. So I'm going to put my program director hat on for a minute and just talk to you about the benefits of genetic counseling. And maybe someday all of you will be meeting with a genetic counselor, so I want you to understand a little bit about the process. Okay, so this is a nice overview. It's an important slide because I want to take a minute here, and I'm going to make sure I keep track of my time, but I'm going to spend a lot of time just focusing on this slide so that everyone we're all on the same page. I will say, in my experience, when I was doing genetic counseling at the Mayo Clinic, I would see a lot of patients with neurodegenerative disorders like Alzheimer's disease. And a lot of people asked me, what is the chance that I have a genetic predisposition and that I could have passed that to my children or my grandchildren? I got that question quite a lot. Okay, so the short answer is that 75% in the blue section of that circle graph, 75% of cases of Alzheimer's disease or dementia are not known from a genetic standpoint just yet. It's what I'm going to refer to as complex or multifactorial inheritance. And I have another slide a little bit later on to describe what that means, okay? The orange section of this pie graph is what I'll spend most of my time talking about, because that is where the gene that you just heard about called ApoE, that's where that sits. And this is 15 to 25% of people with Alzheimer's disease will have some genetic predisposition that is complicated, meaning it's more than one gene, and it's more than one gene combined with environment and lifestyle and just living, essentially. That's where most of people fall out when they have a family history, which is what I'm going to refer to as at least 3 relatives who have been diagnosed with dementia or Alzheimer's disease. That's what we call a familial case of Alzheimer's disease. So 15 to 25% of people will have some genetic factor, many of which are still being identified. And so the ones that we know the most about are the ApoE gene, and that's what I'll spend most of my time talking about. Only 2% or less in the very top part of this pie graph. 2% or less of cases of Alzheimer's disease are truly 100% genetic. 100% meaning I was born with a gene that I inherited from my father or my mother, and because I have that gene, I'm definitely going to have symptoms and I'm going to be developing Alzheimer's disease in my lifetime. And as you just learned, these cases are very young onset. So the ages are 30s and 40s typically. So these are very, very young individuals, and so they're very rare. And then the very last section of this graph is just not sure if everyone's aware of the fact that people with Down syndrome are living longer, and we're realizing they also have a predisposition to Alzheimer's disease. As I just discussed with you, anytime we're referring to the forms that are familial, there's going to be at least 3, if not more, relatives who have, and maybe not officially been diagnosed, but suspected at least to have had Alzheimer's, because as you just heard, the diagnosis is very complicated. And if physicians aren't always aware of some of the biomarkers and the tests available to make a diagnosis, sometimes it's just what you as relatives pick up more than the actual physicians do because you're living with that person. So if you have 3 or more individuals with Alzheimer's disease and there's a younger age of onset, 30s, 40s, and sometimes 50s, that is the form that's very rare. Fewer than 2% of cases fall into this category, which is, I guess, in some ways fortunate. And these are the ones that will carry a gene that they inherited from their father or from their mother. And it happens that such that an inheritance pattern in which probably every generation has had that gene, and it gets passed down to at least one person in every generation. The risk when you have a gene that falls into this category, the risk is 50%. So on the left side of this chart are the names of the 3 genes that are most commonly that have been identified for individuals with very young onset of Alzheimer's disease. In the middle, they describe the inheritance, and autosomal dominant is just defined as there's a 50% chance if I have this gene that I will pass it to each child, and each child has a 50% chance to inherit that. Also, autosomal dominant means men and women are equally affected. And then on the far right, you just see a little bit description of what somebody with this gene how young they may present. What is more common in the general population and probably affects many more of us in this room is an older age of onset, which is defined, and these are just arbitrarily defined by studies and papers and articles, so everybody doesn't fall exactly at this age group, but somebody that's over 60 or 65 and gets a diagnosis older than that, they would fall into this category. And remember I said earlier that that's around 15 to 25% of all the cases that we see of Alzheimer's disease. And there are many susceptibility genes, and that just means that there may be up to 10 or 100 different genetic markers that we were born with, that we inherited from our parents, that increase that risk for somebody to develop symptoms someday. But it's the ApoE gene that I think most people have heard about. It's been around the longest. It's been discussed in so many different media sources, and many people have already been tested for it. So that's the one I'm going to talk about now. All right, back to the biology class. We all love genetics in school, right? I think that most people do not like genetics in school. So I just wanted to take a step back and remind everybody that when we're born, this is a picture of what we call our chromosomes. And the chromosomes carry all the genetic information that anyone is ever born with. And you'll notice that there's 22 numbered chromosomes, numbered by size. The number 1 is the largest chromosome with the most genes on it. 22 is the shortest. And then the last pair are given letters because they indicate whether we're a female at birth, XX, or a male, XY. This just happens to be an XX female. We have 2 copies of every numbered chromosome and either 2 X's or an X and a Y because we inherit one from our mom and one from our dad. So this was just a reminder of how we get our genetic information, nothing more. It just so happens that the ApoE gene is on chromosome number 19, so I put a little arrow there and kind of circled the section on the chromosome. It's on the bottom half of the chromosome, and that just means that we can get a test now that looks at our ApoE gene, and we can determine what our ApoE gene looks like in a laboratory. And there are some implications of the ApoE gene that we're learning about. Now, I'm not a cardiologist and I'm not a neurologist. I'm a genetic counselor, so I'm just going to explain briefly what I know about the ApoE gene is that it was involved initially in developing cardiovascular disease. So it was used primarily by cardiologists for looking at risk factors for heart disease. But somebody did some research and found out that by and large it also has a role, and I emphasize a role in the possible development of Alzheimer's disease. It by itself is not causing the disease. As I said earlier, there's lots of different genes, many of which we're not aware of yet. Now, I don't want to get too far into the weeds here, but there's different forms of ApoE that any one of us can have. And you see the numbers there, epsilon 2, 3, and 4. And because you see two with each one, that means we inherited one from mom and one from dad. So on the far left, if I got two ApoE genes that were little e2, which is epsilon 2, epsilon 2, if I got that one from mom and one from dad, I might be at a lower risk to develop Alzheimer's, but the point is I could still develop it. Just means my risk factors aren't as high as somebody that has a higher risk, which is two ApoE4 alleles, one from mom, one from dad. There have been studies that have been done over the years that are looking at quantifying what is the numerical possibility that if my genotype, E3, what is the chance I'll develop Alzheimer's disease? And so that's been just estimated to be anywhere from 10 to 20% by age 75. If I'm E4, it's 25 to 35 by age 75. So you're just looking at numbers. A number is a number. What we make with that number is what matters, meaning to some people, 35% sounds low, and to others, it sounds very high. It really depends on what that person thinks about that number, okay? And then finally, I say up there that even with the high risk E4, it doesn't mean that you're necessarily going to get Alzheimer's disease. Everyone's going to be different. In fact, 42% of individuals with Alzheimer's disease who have been tested for ApoE do not have the high-risk alleles. So they did not inherit both copies from their parents. And then, as I said earlier, the epsilon 2 might have a protective effect. So just to finalize this component, down at the bottom is a very colorful picture of everyone's chromosomes. We're moving into this direction in genetics where everyone's getting all of their genes analyzed at once. That's called whole genome sequencing, and then they have to sort through the different genes and identify different variants that you were born with, and that's another way that we're going to look for these risk factors to develop Alzheimer's disease. So there's more work to be done and a lot more understanding of what this means to our lives. So I'd like to just conclude my presentation by reminding you a couple things. First of all, most people don't have a genetic predisposition that's at least identifiable, and it's really just an effect of a combination between our environment and our genes, and it's really hard to predict at this time. Now, this will change in 5 years, and in 10 years, this will look very different. So anyone who's interested in learning their status, whether it be ApoE or especially the early onset, if anyone has heard of any friends or family that have had really early onset, we highly recommend following a very strict protocol where individuals start with genetic counseling to understand all of this information and what it's going to mean to them and their family members and their lives and how will it affect them, followed by neurological assessment, a psychological assessment. How is that person baseline? Do they have a propensity for depression or any mental illness that could change the consequences of having a genetic test result? They will need more support. They may need to be treated for that before genetic testing actually starts. And then a second genetic counseling visit to answer any follow-up questions before the actual blood draw. So in an ideal world, if we had enough genetic counselors in the world and people that were trained in genetics, this is the protocol to follow for all the testing I talked about this morning. And then in an ideal world, I would love to be able to see my patients for many, many years, for as long as I'm practicing as a genetic counselor. But as we all know, that's not always possible. Okay, a lot on this slide. I'm going to just leave it up there for you to look at. But what I'm referring to with this slide is that we've done a lot of this type of genetic counseling in the case of cancer. And you heard about that with the genes that are available for ovarian cancer. So we have a lot of experience with these types of protocols, and we know how to make them work, and we know how to do them. We just have to implement them into neurology clinics. I'm going to end here. I think I'll be a minute or two over, but pretty close to time. These are questions I won't say them all out loud, but these are questions that I would like everyone to think about before they undergo genetic testing. You heard about the chance that someone's going to develop symptoms. If they get the genetic test and they're positive, it's not a guarantee that they will develop symptoms, and they may test negative and still develop symptoms. So there's a lot of unanswered questions, and so before somebody gets this information, I'd love to have people really think about, how's this going to change what I'm doing in life? How am I going to talk to my family or friends about this information? Will I get a different job? Will I quit the job I'm in if I can? Will I go to school and pursue a degree I've always wanted to do? Will I travel the world? Will nothing change? Will I just continue on as I am? What about my job? Do I have to disclose this to my job? Will I lose my health insurance? Will I be able to get life insurance? There's a law called the Genetic Information Non-Discrimination Act, and it's GINA, an acronym for short. This is a law that will protect anyone with a genetic predisposition for any disease from losing insurance, being denied health insurance, being dropped if they already have insurance, and it also prohibits job employers from asking them to get genetic testing or what your results are. There are limitations to the law. It doesn't protect federal employees, it doesn't protect people in the military, and it doesn't protect companies with fewer than 20 employees. So there are some limitations that people need to know. It also doesn't cover long-term care insurance or life insurance. That means a life insurance company could discriminate against me if I knew I had a genetic predisposition to cancer or Alzheimer's disease, as an example. So if I'm the breadwinner in my family, and I am bringing home the paycheck for my family and my kids, then I need to be sure I have all that in place before I get my testing. Benefits of knowing is I could plan my future off for my family. You heard about the personal experience. Once you have kids, you might want to know for them, but do they need to know? It may reduce my anxiety. It most importantly could determine eligibility for research studies, which would be really exciting because you heard about all the benefits that could come from that today. Finally, some people just aren't ready, and that's okay. And that's the message I want to end on, is that if you're not ready for it, you want to do just the biomarkers and do PET scans and not pursue the genetics because of all the issues it brings up with family members and your children and potentially grandchildren, etc. That's okay. There are other ways to pursue this. People have sometimes not processed grief from losing a family member, and they may not have their finances in order and may want to get some of that done ahead of time. And that's all. So I have my email there. I'm happy to answer any questions that anyone may have in the future. And thank you so much for your attention.
Thank you, Dr. Hunt-Brendish. Next we have Shelley. So Shelley, we're lucky to have her here today. A little about her. So she's been married for 43 years and has 3 children. Her business, well, let me start with what you heard this earlier, but so she's enrolled in an Alzheimer's prevention clinical trial. And she has that real world experience that is so important to hear about. Her business career spanned 35 years as a CPA, a CFO, and a business owner. She sold her business in '99 and continued working as a regional president for companies that are now part of Home Depot. She's retired and has enjoyed life here in Arizona in the past 12 years. And a year ago, she inquired about this trial for lecanemab, and she'll share her personal experience about what motivated her to do that and how it's been going. Thank you, Shelley.
Good morning. Do I look like him? Oh, my God. Yeah. I am very happy to be here, and thank you for coming and your interest in all of this, including the clinical trial that I'm going to talk about today. And just so you know, I chose to use only my first name, as only my family and best friends are aware of this diagnosis. So, shh, you're all now my best friends. I really didn't want it to get out there into the universe of people just yet, because I am considered preclinical, which you heard from Dr. Cabral, and I don't have real noticeable symptoms at this point in time. So I'm leaving it kind of close to the vest at this point in time. But I do have the ApoE gene 4, and I do have symptoms that were detected through some of the blood work, as I will explain when we go through this. As Dr. Cabral mentioned, I have had a great life, wonderful family, interesting career. I considered myself intelligent, and I have tremendous recall for details. In 2010, at the age of 57, I was diagnosed with breast cancer. And fortunately, I always did all my mammograms, did all the early detection, and now I'm a 13-year survivor of cancer. So I've been through life-threatening things. Thank you. But I took stock in the direction of my life, and I retired to Arizona, and that was such a great decision for us. My husband and I are avid golfers, and it tells you how important I think this is this morning, because I'm here instead of on the golf course for you. Yeah, well, okay, it was raining. Yeah. So, how did I get here? Well, I am my mother's daughter. And people always said that about us when I was growing up. We looked alike, we even sounded alike. When my mom was 80, she asked me, how do we make tacos? And I kind of stopped dead in my tracks. This was a meal that we had about every week when I was growing up as a kid. So her cognitive abilities had started to decline at 80. And over the next 8 years, I was the primary caregiver along with my father, and we watched every step as she declined. So I'm very familiar what's going to happen, and she passed at age 88. Long track. From that day forward, I always had it in the back of my mind that that would also be my fate, not knowing anything about genes and biomarkers or anything like that. But being the academic person that I am, I tried to read everything about dementia and Alzheimer's, hoping for a cure. 1 year ago, I saw an article in a magazine about a clinical trial, and for a new drug called lecanemab, and a blood test that could detect genes that identified with Alzheimer's. So I gave it a shot and made a phone call. There are mutual questions back and forth about the trials. It piqued my interest, and my mom's history also drew their attention. Now, over the next 3 months after that, there were a series of steps for this clinical trial that I went through that I just want to share briefly with you. The next step is I had a face-to-face interview with one of the clinical physicians. She carefully went through the details, talking about the steps, including time expectations, the risks, and the results that have occurred with lecanemab. She also explained that at any time I had the option to opt out if I became uncomfortable or decided to leave the program. And that's still the case today. Next came some cognitive tests, and not just the clock face, but this was an all-morning series of tests that were very comprehensive, and a simple blood test. And at this point, after that point, they told me that they did detect some abnormalities, so we both agreed to keep going. So this is a step-by-step as you go through this. Then came a physical, more blood work to test for the genes, an MRI, an optional lumbar puncture, and it is optional. I did opt for that. And Dr. Cabral did it, not a pain in there. Yeah, not quite. Yeah. After that, all the results were discussed with Dr. Cabral and my assigned doc and my husband. And learning that I had that ApoE gene and the possibility of going forward, they did say I did qualify for the trial. Then came the decision time for me. And I was surprised that it had started at all, as neither my husband nor I saw any cognitive decline. And I knew that gene testing of full availability to Medicare patients and all that has been explained is not yet available. and that for the trial, I only had a 50-50 chance of receiving the drug, but 50% to me was better than 0 at this point in time. It's not easy, it's not for everyone, and Dr. Brendish had the perfect list of things to consider as you're going through this, and it's okay if you decide not to do that. But if you don't get PSAs or mammograms, or if you don't watch your cholesterol or glucose, that might not be. Some people just simply don't want to know, and that's okay too. In the end, a couple of things really helped me say yes. I've always been a planner. My husband and I planned for retirement, and gosh darn it, we have had a great retirement down here in Arizona. I'm a volunteer, and I consider myself a giver. And I'm happy to give back to my community. This trial will help all of us one day, and a simple blood test and a pill is in the future for us to stop this terrible disease. And I'm very proud to be a part of it. Most importantly, I knew when I looked into my youngest daughter's eyes, this is the hard part, because she is her mother's daughter. And for her and my sister, my nieces and nephews, I want to go through this because I want to be the last one that has to suffer through this. So I entered the trial, and I've been taking infusions on a regular basis since July. I haven't had any side effects. The staff that I work with are beyond professional and caring. If you need a ride to and from your infusion, they assist you with that. Each infusion starts with blood work so they can monitor your progress. And as a precaution, after your first couple of infusions, they ask you to stick around for 4 hours just so they can make sure that no side effects do show up. So they're very thorough with this. And lastly, the diagnosis of Alzheimer's, I consider that I also received a gift. And the gift is that I will never take another day for granted. I feel this way because, like all life-threatening events that I've actually been through, it brings the important things to focus. And I don't intend to waste my time with self-pity. I intend to do something about this, which is why I'm here today, and hoping that you also consider this. And it isn't easy, not for a second, but I'm happy that all the small stuff falls away, and I'm finding joy in every life today. So what's really important to me, Dr. Cabral, you asked that question, is you work harder and faster and get busy, would you please? Because we really need this to go. So thanks for listening.
Thank you, Shelley. Another round of applause for her courage. Now, last but not least, we have a Canadian here. We have Dr. Jason Scott Robert. Now, I first met him when I was in medical school at the U of A in 2007. He was the bioethicist on board, and so I appreciated his perspective that was different from a lot of the science classes we were taking. And so he trained and worked as a philosopher and ethicist in Canada before joining the faculty in the School of Life Sciences at ASU in 2004. His teaching and research are at the intersection of bioethics and philosophy of biology. His scholarship currently focuses on the justification of research in the translational pipeline from bench to bedside, and his research has been funded by the Office of Research Integrity of the U.S. Department of Health and Human Services, the Defense Advanced Research Projects Agency, the National Science Foundation, the James S. McConnell Foundation, and the Canadian Institutes of Health Research. Wow. So thank you for being here, Dr. Robert.
You know when you show up at something and you are obviously the least desirable part of that thing? That's what I feel is going on here. I'm competing with these incredible women who are leading the way, and I'm also competing with your time that you've all donated this morning and we want to make sure we have plenty of time for questions. So I'm going to keep my comments really brief. I'm going to say a couple of quick things. First off, I realized this morning when Catherine told me that she got her PhD 10 years ago that I'm getting older. Danny and I've known for 15 years now, more than that. ARP writes to me on the daily asking me to join. I'm only 51, so I'm going to give it a year or two before I give in. But one of the things that started to happen to me in the last 2 or 3 years is I actually started to pay attention to biomarkers that matter to my own health. And one of the biomarkers that we kept track of, we keep track of all the time with fat guys, is A1C, and which is a biomarker for diabetes. And so I had this really fun summer, last summer. In the week before I turned 50, I had an asthma exacerbation that landed me in the hospital for 6 days. And then 2 days before my 50th birthday, I was told that I have diabetes. And it was wildly, massively uncontrolled. I mean, my A1C was over 11, which, for those of you who know anything, it's astonishing I'm still around. But no, it's perfectly tempered now, 6.1, where it should be, which is really nice. So then I thought, hey, if I'm doing all right with that, I might as well make an appointment with a cardiologist. That was last week, pulmonologist the week before, gastro on Monday, and I have a sleep study in December. And I realized that the reason I'm doing all this now is because I'm finally starting to think, maybe it's because I know my life is at least half over, right? You sort of, once you hit 50, you sort of think you're in the second half, you know? It's unhappy if you think that when you're 28. But when you're, at this point, I'm okay with that. And I started to realize that what I've been doing is sort of what I like to call life planning. And, too often we talk about, we don't talk about life planning at all. We sort of live our lives. And, living your life and living it well is fantastic, but planning is absolutely critical, as we heard from Shelley, especially if you want to be able to enjoy your later years. And so I finally started. I got my finances sorted. I got all these healthy things. Still haven't lost an ounce, but I think that's going to come next. And I realized this life planning thing is absolutely critical. And I started to think through some of the kinds of questions that Dr. Hunt-Brendish was asking. Questions like, what am I most afraid of? What am I most looking forward to? What keeps me up at night? What are some medical procedures that I'd be totally happy to undergo? What are some that I would absolutely flat out be unwilling to do? Turns out, after watching a little video and hearing Shelley's testimony, I'll gladly get a lumbar puncture from Danny Cabral anytime, but
I got one for you.
Pretty well only her. And so what interested me about this, though, is even though I've been thinking about and lecturing about aspects of ethics of clinical trials and whether we ought to participate or not, I'd never participated in one. And I still haven't, because I'm just too fat. As soon as my BMI drops a bit, then I get to qualify, but I don't qualify yet, which I think is unfortunate, because there are lots of fat people who need to get healthy too. And yeah, but nonetheless, I started to think about this idea of participating in clinical studies, and as my mom, she's recently gone blind, and my, with my own issues with my endocrine system, I started thinking, maybe that's next for me. So I'm starting to get to the point where I'd like to be able to join a clinical study where I can, no matter what the context would be, something that might improve my health or something that might actually just lead to an expansion of the knowledge base, which is something we all need. Danny and her colleagues are at the forefront of expanding the evidence base, the knowledge base for progress in Alzheimer's disease prevention and treatment. We've got experts like Catherine, we've got pioneers and guinea pigs like Shelley, and we've got all of you in the questions that you've got before you. Hopefully you've passed them along to the ends of the aisles, and I'll be able to turn it over to our, is it Jan, are you going to be running this section? I think Danny's going to be running. Beautiful. I am going to turn it over to Danny Cabral.
It's better if you write them down so we can take care of duplicates in a way, so we can really get to the kinds of questions. And there's no bad questions, so please write them down and raise your hands if you got them. And then
Great. So thank you all very much. Please write down your questions and learn from these gurus.
Hello. Yep. All right. First question is for Shelley here. So, would you talk a little bit about or share the thoughts, feelings, and emotions that you experienced when you found out you had those abnormal Alzheimer's biomarkers? Even though you say you're your mother's daughter, and you know, but when you actually heard it, how was that for you?
Well, my husband was sitting there with me when they explained that, when Dr. Cabral explained that. He didn't think he heard it right and said, oh, no, she's fine. No, not. But it was a hard pill to swallow. It really was. I came in there with that meeting, however, I said to myself and to my husband that I'm going to expect the worst, and if it's better, then I'll rejoice. So I really went into there bracing myself that I would have that type of diagnosis. So I didn't cry until that night when I went home, but emotionally, it does get to you, and you do have to take your time to grieve. It's a form of grieving. Go through the process. It was a little bit of a shock, but then not, so I was able to pass through that part of the grieving piece quickly, if you will, before I got to that, back to the acceptance stage.
Thank you, Shelley. For Dr. Hunt Brendish, what is the process to get genetic counseling?
Oh, that's a wonderful question. Thank you, Dr. Cabral, and thank you, whoever asked that question. So this is where it gets a little tricky, and I'm going to be honest with you about my disappointment about how challenging it is to find a genetic counselor. So maybe that can become my mission now, moving forward. Essentially, in a nutshell, genetic counselors are employed at all the major hospital systems in the Phoenix area. Mayo Clinic, Banner has genetic counselors at all the Banner sites around the city. Honor Health, Ironwood Cancer Center, Phoenix Children's Hospital, and I think, did I miss anything? And St. Joe's Dignity, thank you. That's it, yeah, that's it. So essentially, to find a genetic counselor, most of the time you would go through the oncology department, and I know that sounds crazy, and that's one of the problems and barriers to all of you accessing our services. Because we don't have a formal neurological genetic counselor, or we call neurogenetics genetic counselor, in any of those systems, they all sit in the oncology space. So you would call the cancer center or the oncology office. The genetic counselors that work there do see patients with neurological disorders. I am motivated because of the training program and other various reasons, even personal reasons. I'm motivated to get more genetic counselors in the neurology space at Banner, especially, and Mayo Clinic as well. So we're working towards that, but hopefully that gives you a little bit of an up. If you took down my email, if not, it's khuntbrendish@asu.edu, and you want to email me personally, I can help connect you as well.
Or you can email me at jsr@asu.edu, which is way easier, and then I'll forward your message.
This is for Dr. Brendish also, I think, or yes. Can they take away long-term care insurance if I qualified before finding out my biomarkers, I'd say or genetic or ApoE status? Or maybe I should.
I think you should answer that. I don't know, but I would be a little... No.
So I would say in terms of the biomarkers, at this point, we're not far enough along that the long-term care insurance, I think, could interpret what those mean. And because even if you have elevated amyloid or abnormal amyloid and tau, we don't know for sure when you might develop symptoms. And some people actually have an abnormal PET scan, and then for years they're stable. And that could be what we call resilience or cognitive reserve or just lucky. We're still learning about that, but I don't think at this point it's more about the clinical status. And for long-term care insurance, and Jan, you might be able to answer this better. And also, I've heard, different senior living communities also, want to make sure you seem to care if you have symptoms of dementia before they'll allow you in. So, but I don't think the biomarkers itself at this point.
And I think I was just talking to Dr. Robert about the genetic piece. If you already have long-term care, it should be fine. It's the new policies that you're actually applying for where you would, by law, you would have to inform them that you carry.
Never lose it. So I actually have a family friend who was thinking, we pay for a lot of different insurances. Maybe we shouldn't worry about all this stuff so much, and canceled their long-term care insurance. This is my friend's father. And as a result, it took them about 15 more years to be able to afford to move from their home into an assisted living facility. So bear that in mind.
Thank you. Are there blood tests for non-Alzheimer's dementia, frontotemporal dementia, Lewy body? Ooh, this person knows what they're talking about. PSP, progressive supranuclear palsy, or cortical basal degeneration. So there are not yet blood tests available. Where we're at, I would say the farthest along is Lewy body disease, where because it's in the Parkinson's family, so Lewy body and Parkinson's all have they all have Lewy bodies actually, but in Parkinson's, so these are alpha-synuclein deposits where, so alpha-synuclein is the protein abnormality, and in Lewy body, they're in the outside of the brain, the cortex, where the cognitive functions reside. That's where they start, and in Parkinson's, they're deeper where the motor function resides, like the basal ganglia, and then they go on to spread, so then you can't really often tell the difference clinically between someone with Lewy body or Parkinson's. There's a big overlap. So Parkinson's disease, and this is another question, where we're at is there's a cerebrospinal fluid test now that's been validated to identify alpha-synuclein elevation, and so I'm suspecting soon that will be for Lewy body also. That will become something we can deploy, but I don't know anyone that's used this clinically. It's very new. It's brand new. And then someone asked about I'll just go back and say, this is the value of the more people get involved, especially in research. And today wasn't all about getting you and sneakily trying to get you into a research study, but the more we get involved, the more we can clearly identify those who don't have Alzheimer's disease. Those are normal, those biomarkers, but there's something going on. And then that's when we're going to learn more about these other non-Alzheimer's pathologies. And then other ways that clinically, someone asked about a skin punch biopsy, and so that's something that we're doing at the Anderson Health Research Institute. So that is now being looked at for Parkinson's, and it's fairly accurate, though they're working on getting the most precise technique to doing this, to studying this, and that's a really easy one, right? If you can we're doing it on the kind of upper back. It seems apparently that's going to be more accurate than if you did a skin punch biopsy on a leg, maybe closer to the brain, I'm not sure. But so that may end up being for Lewy body also, so that's exciting as well. So that's on the horizon, and again, people always come up to me after these talks and they're like, but this isn't helping me now, or my person, and I would just want to say that I know. And so 2024. All right, so this is for Shelley, and I might chime in on this also. Is the trial that you're in only for, they say, early stage or preclinical Alzheimer's? My husband is moderate stage. Is he too far for this disease to be considered for the infusion trials? So, okay, yeah. So what we found is when these anti-amyloid monoclonal antibody infusion treatments were first getting going 15 years ago, people who were farther along were not benefiting and they were having more side effects. And so it's not, those aren't going to be the treatments, but, and so there are research studies that are more symptomatic in benefit to help people who are in the mild to moderate stage of Alzheimer's disease. So we have a few specialty centers around around Phoenix area that do treatment trials. So I can talk to someone after about that. And then how is, yeah, please.
So she does the diagnosis and treatment. I've done the care. Okay, so we all need care following any diagnosis. So a diagnosis is good, but the care is what we need. So we have got some amazing resources out there. There is no reason any of you should go at it alone. Okay, we've got the Alzheimer's Association, Duet, we've got Tempe Adult Day, we've got Oakwood Creative Care, we've got Banner, we've got Barrow. We have memory cafes, new one starting in Chandler. Don't go at it alone. It is tough. There's no magic pill. Everybody is different, but you should not be alone. We are still years away from treatment. That's the sour reality. I mean, I love where we're at, but we're a long ways out if we're honest. We all need care. And so please don't leave here today without finding someone who can partner with you, okay? These folks are fabulous, but we need care. That's all I'm going to say, because it's about the care.
Amen. And so with the blood test, so say they just started, primary care doctors or providers just started doing the blood test even before there's any symptoms. So then you have an increase in Alzheimer's diagnosis by, 1,000%. But still the care, isn't there. And so part of that, I think, is on us to, again, get out there, join together. I mean, this organization, this effort is so much farther along than most places. But this will eventually become a disability. And then so we'll have to adapt lives as people are living longer with the diagnoses. But yeah, it's all, I think, about advocacy. And okay, so different topic, how is tau removed? So after anti-amyloid treatment research came along, then there was tau, and the studies that have been done so far, that have been completed, have been negative. And so while this is a good example, so they decreased the tau, but the symptoms proceeded as expected for Alzheimer's disease, and this is where chasing a biomarker didn't get them anywhere. But there is a trial, this is just, the beginnings, but of a treatment that's intrathecal, not fecal. So intrathecal, and that means it goes through basically like a lumbar puncture spinal tap. So you have the treatment infused that way, similar to what's done with a lot of brain cancers. And it's getting right in there. And that is showing that the tau is decreasing, and there is a signal that that the symptoms are slowing down. But this is still very new. But I think, and there are actually very few side effects. And I can talk to anyone about this later if interested. But I think we need to be, try new things. And that makes sense to me. Get right to the source of what's going on. Okay. So should an 80-year-old with moderate dementia get the blood test or PET scan if they have not had them earlier? How should I get this done? So none of these things are yet covered by insurance. So right now you wouldn't have it done unless you're going to pay. And a PET scan is anywhere from $4,000 to $8,000. Now the question is it going to change anything if a person has moderate dementia? And I would say if there's atypical symptoms, like maybe they're having some changes that look like it could be Lewy body disease, this is when this is available. And so maybe it's not even worth talking about this, but it would be worth knowing, is this Lewy body disease? And primarily, because that's a complicated, challenging disease that the more patients, the more families understand what's happening and what to expect, the more I think you could prevent unnecessary medications, falls, hospitalizations, death. sooner, placement, because for me, I start to, sorry. Yeah, I know. I think the families of people with Lewy body disease really, have an interesting perspective, and we should hear from them. But somebody who comes into me as a provider the first time and they're on like a drug from 6 different classes of psychotropic medications, and I'm like, they have Lewy body disease. Like, I don't even need to, But that's what ends up happening. And so that might be a situation where eventually it will be helpful to get these tests. And
yeah, a real quick thing. Jan pointed out that we don't have to be alone. That there are a lot of resources out there, and connecting people with resources is absolutely critical. And one of the things that we saw in the presentations is connecting with an excellent clinical care team is absolutely essential, but so too are the community resources, like the ones available here, because it's far too easy to imagine ourselves sort of in Auguste Deterre's shoes, as somebody who had lost herself, and we just see her now as all alone and lost. There's no reason for us to feel that way in particular. And so even though the prospect of the loss of self is still terrifying, there's a lot of good to come from, who am I and who do I want to be and how do I want to live in that kind of life planning sooner rather than later. Where
yeah, I missed that. Thanks. Wouldn't it be great if insurance covered like a comprehensive life planning session where you could reflect? Well, because what I often as a clinician have called myself a retirement coach, because basically what I see is all these amazing people that have had all these accomplishments, and many are not doing much with their days, and they don't have a good routine, especially with COVID, which decimated all of our routines. And I'll prescribe donepezil and do those things, but like we spend a lot of time talking about like what's important to you, what do you enjoy, what used to be a big part of your life and has been missing, and why is it missing, and how can you get back into that in like a small way every day and make it part of your routine. And then when people come back and they feel better, and that's why, I think the donepezil against the Aricept, it does help. I don't think it's been shown, but we need to implore the payers to recognize how important this is, and that's what early diagnosis could be beneficial, is if we had all those resources and a team to help people to figure that out and implement those things. Question for Shelley. Would you share how you came to your decision of who you disclosed your diagnosis with and the timing of that, and anything else about it?
I touched on a little bit when I was talking today, because it first starts with you tell your loved ones about your family, make sure they understand what's happening. Even within my family members, I did it a little differently. The youngest daughter, who really is a lot like me, and I really suspect she's at high risk, I told her directly and told her everything. The other thing, one of the other children, not so much. I had to ease them into it because I felt they were not ready to handle it. So it was, I now have the gene, and I have a 35% chance of developing it. That's it. So just to let you know, I'll keep you updated, sort of thing. But and same thing with my good friends, people that I know that I can count on, and people that I will need to count on later on. I wanted to be upfront with them so that they are aware we can all do this planning together, and I include them in that. That was very important to me. The rest of the people, not so much yet, because the minute and same thing in my thought process, the minute I tell somebody I have preclinical Alzheimer's, six minutes down the road, someone down there is thinking I'm about to die from Alzheimer's. I've got it, and I'm late stage, and I just don't need that social problem.
For Shelley again, what was there a difference psychologically and emotionally in getting a breast cancer diagnosis versus preclinical Alzheimer's?
Breast cancer was more of a shock, real shock, because that was 13 years ago when I was 57 and still working. That one scared me, and I felt like, okay, now that had to be my singular focus and to beat this thing. As an aside, I had been doing and it was Susan Komen at the time, I'd been doing fundraisers for Susan Komen, and we were out talking about mammograms and things with everybody, but that was scarier. That involved 5 surgeries in a year. I'm a double mastectomy, that type of thing, and a lot of unfortunate drugs after that, tamoxifen, which gives you what they call chemo brain, and I don't think I truly recovered from my total faculties after that. So that was probably the scariest one.
Just a couple of quick hits. What physical and mental exercises should you be doing if you're a child of a father who passed away from Alzheimer's at 78? So midlife, the research is clear that aerobic exercise, so meaning anything that's going to get you sweaty, is going to be helpful. And so the sooner you start that, the better. And that's going to be, I always just say, you got to do something that you'll stick with. Right? So I don't tell people to go to the gym for 45 minutes 3 times a week. I'm like, so what do you like to do? You want to dance in your kitchen? Great. Whatever you're going to stick with. But aerobic style seems to be coming up as beneficial to delay the progression, basically, of symptoms of dementia. Okay, great. There you go. A living example. And there's longitudinal community studies specifically of women in midlife that show directly the risk of dementia 20 years later correlates with how vigorous the aerobic exercise regimen is. Like, so if you're 50 and you're like the best exerciser, you have the lowest chance at 70 of having dementia, and then vice versa. Then for Dr. Hunt Brendish, you said age of onset, do you mean age of diagnosis or age of first symptoms, which could in fact be 10 years prior to diagnosis?
So age of onset would be first symptoms.
Okay. And then this person was told they have no ApoE4. Thoughts on accuracy?
Well, I think you just take it with a grain of salt, honestly. Take it with a grain of salt. Look at everything else going on in your family. Look at your lifestyle. It's a good thing. I think I would look at it as a positive emotionally and take it with that.
So it's a fact. You don't have ApoE4. You don't have to get tested again. Okay. Is there a central site online for clinical trials in Arizona? So I would say go to clinicaltrials.gov, and that's where you're going to just put in search terms, Alzheimer's disease, and then Arizona, and then everything will come up.
Yeah, that's the national database of all registered clinical trials for all.
Say that again, please.
So the website.
Clinicaltrials.gov.
Thank you.
CLINICALTRIALS.
Thank you.
Great. And then in French, so how to find a practitioner who is familiar with Alzheimer's blood tests and biomarkers and accurately interpreting results. So that's difficult, and it's only going to be really truly at the centers, the specialty centers. So here it's Banner, Barrow, Mayo. Maybe some of the general neurologists who have a special interest in Alzheimer's, but I can't say specific names, so it's very limited. And you're lucky to be in a big city where you can access these people, though it may take time to get in. If you are in a clinical trial or research, though, you are going to have access to them immediately. Then what with dementia patients, how do you change a person's focus on a bad habit, such as drinking? That's another summit topic. Just I find that as a clinician, some people come in who have dementia, say mild to moderate, and they assume I'm going to be like, drinking is bad, no drinking, and it's like I'm the principal and they're the high school student, and so I try to change that dynamic to, hey, you're a grown up, like, but this is what we know. You have memory loss, you have Alzheimer's. We know alcohol is a neurotoxin and it's killing your brain cells, so it's going to speed up these symptoms. And depending on the situation, some people get more combative or aggressive when they drink. Some people are more sedate, and for the care partner, maybe that's not a horrible thing. But at the same time, I say 1 to no drinks a day. How do you change a habit? That is such an exciting topic now that people really care about, is habit changing. So, all right, this is such beautiful handwriting. Can I just read this? Okay. If my memory analysis shows I'm likely to already have dementia, can I take Prevagen or similar over-the-counter med to prolong a healthy memory? Are there drugs that will be prescribed by any neurologist like Aricept when my memory tests indicate I have a problem? So the Prevagen, the memory supplements over-the-counter, all in significant or systematic reviews show they don't actually help or meet the claims that they make. And so we say if it probably doesn't hurt you, but it won't help you. It's costly. So and then treatments, yes, neurologists, absolutely. So Aricept or donepezil is indicated for any stage of dementia and mild cognitive impairment. Even we prescribe it, and it does help modestly symptomatically. And Lewy body disease can help things like hallucinations. So there's a lot of benefits to that. Another summit topic, or day-long, seminar. So it's the second most common neurodegenerative cause of dementia, but it's much less common than Alzheimer's disease, and it sort of looks like a combination of Parkinson's symptoms with motor dysfunction, tremor, and then memory loss.
But that is less common than Alzheimer's is maybe an artifact of overdiagnosing Alzheimer's and not appropriately diagnosing these other forms of dementia. So we'll reassess that.
So it is 12 noon, and first of all, thank you to Dr. Cabral, amazing panelist. So your feedback to us is really important. We will actually start planning for our 8th annual summit just a few months from now, so we always welcome input, and certainly we had a lot of things we could talk more about today, but we thank you for your attention. So please fill out your evaluations, drop them off on your way out, and then our lovely caterers are pointing that we have extra food. So please, don't be shy, help yourselves on the way out, and our vendors will be here for another 15 minutes or so as our speakers, so feel free to visit. And again, please don't be alone. This is what Dementia Friendly Tempe is about. It's about connecting you and the person you care about to the things you need most. Thanks for being here today.